Friends, today we are going to discuss about the definition, clinical phenotypes and pathophysiology of bronchial asthma in this module. Let's first see how we define asthma. Has there been any change over the last couple of years? We all know that asthma is a heterogeneous disease usually characterized by chronic airway inflammation. It is defined by the history of respiratory symptoms such as wheeze, shortness of breath, chest tightness and cough. But what is very important is that it varies over time and in intensity, together with variable expiratory airflow limitation. That is very important. So the important component is that there is a variability over time and in intensity. Variable symptoms of wheeze, shortness of breath, chest tightness and or cough, and this leads to variable expiratory airflow limitation. Usually this is triggered by factors like exercise, allergen or irritant exposure, changes in weather or viral respiratory infection. Symptoms and airflow limitation can resolve spontaneously or in response to medication. That is what leads to variability, and sometimes altogether symptoms may be absent for months or weeks. Episodic flares, which are also called as exacerbations of asthma, can be life-threatening and usually have a significant burden over a chronic stable disease. Airway hyperresponsiveness to direct or indirect stimuli and chronic airway inflammation usually persist even when symptoms are absent or lung function is normal, but may normalize with treatment. What it means is that airway inflammation, which is an inherent component of the asthma, it persists. Even person may be asymptomatic. It may disappear on its own or spontaneously, or more so by the use of treatment. When we talk in terms of pathophysiology of asthma, what we all know is that today asthma is defined, as we had discussed just now, as an inflammatory disorder. Now the question is what causes this inflammation, and we all know that usually it is driven by IgE dependent mechanisms. But at the same time, genetic factors also play an important influence on the development of atopy, which is a predisposition of an individual to develop allergic diathesis, and also the expression and inflammation which leads to expression of atopy clinically in the form of allergic diathesis. Environment factors are as important in determining whether an individual will develop asthma or not. In simple words, person usually will have a genetic predisposition. Over and above, the environmental factors will play a role, which ultimately leads to inflammation in the airways or at other places, which gets manifested in that form of bronchial asthma. When we talk in terms of genetic predisposition, one of the important things we have been talking and discussing about is atopy. That is, person's predisposition to develop allergic diathesis. Now today we know that the candidate gene studies have identified number of genes, polymorphism is there, which are responsible or predisposes people to both developing asthma as well as atopy. These genes have been found to be involved in a variety of biological processes, primarily Th2 inflammation, which drives the eosinophilic responses, as well as the T cell regulatory functions, in addition to the HLA locus immunity and immunoglobulin responses of the B cells. Positional cloning using linkage studies have identified problems at certain areas which are thought to be involved in atopy, and these are the genomic wide association also show problems in interleukin 1 receptor, interleukin 18 and so on and so forth. Now today we understand that though asthma has been defined as a Th2 disease which leads to eosinophilic inflammation, but at the same time today we are getting to an idea that it is not only a Th2 related disease, but it is becoming more and more disease of T cell dysregulation. That is what is important. When you look at the component of a pathophysiology, it is a complex, because we know asthma is a heterogeneous disease, and therefore there are different mechanisms which are working in it, and most important of all the common pathway of factors associated in the development of asthma are either airway inflammation, which is leading to intermittent airflow obstruction, and obviously the bronchial hyperresponsiveness in relation to the irritants or allergens. When you see this in this cartoon of airway inflammation, when the antigen is presented to the mast cell, there occurs a degranulation which leads to release of histamine and leukotrienes or chemokines, which is LTB4, which leads to immediate intense acute bronchospasm or early response. On the other hand, along with it, when release of pro-inflammatory cytokines are there, a dominant role being played by interleukin 4. It acts on T cell. T cell subsequently, along with IL-4, it gets primed, and then you have effect also on B cell. When these things are acting, that B cell leads to formation of immunoglobulin E, which again tends to act on mast cell. Similarly, if there is a predisposition or person has already been exposed to allergen, B cell as cell gets activated. Now the T cell, in addition to interleukin 4, they release interleukin 5. These interleukin 5 have an effect on both neutrophils as well as eosinophils. And now the net result is that there are large number of cytokines, chemokines are released, they get activated, leading on to inflammation. Now same time, macrophages are also along, and they get into macrophages, and these macrophages also release to discharge of pro-inflammatory cytokines. The net result of this is it leads to inflammation. This inflammation is there, which could be acute, then there could be chronic, in between subacute. So varied component of inflammation is there, and the acute, as I said, is primarily responsible for causing acute bronchospasm. Then there could occur late responses, and because of persistence of inflammation, there can occur modification, remodeling, and persistence of symptoms of bronchial asthma. When we continue with it, the other way the antigen can present in addition to mast cell is by presentation to dendritic cells. When it presented to dendritic cells, it presented to the naive T cells or T lymphocytes. Now depending upon the amount or the type of cytokine which is released, it decides whether there is going to be a Th1 or Th2 response. Primarily Th1 response we see in cell-mediated immunities, but there could be a genetic predisposition factor because of which we tend to see a predominant Th2 response, which is responsible for the release, as we discussed previously, of interleukin 4, interleukin 5, interleukin 39, and interleukin 3. So large amount of cytokines are released. When you have an interleukin 4, it has an effect both on the increased release of immunoglobulin E from mast cells along with from eosinophils. And what we see along with it is when this activation takes place, there is a mast cell, basophil, eosinophil, all of them get activated in addition to colony stimulating factor. When this cascade of cytokines which has stimulated and along with it has enhanced this inflammatory response, the net result will be additional mediators of inflammation, which includes leukotrienes, histamines, prostaglandins, that is cyclooxygenase pathway, etc., are released, and end result is bronchial obstruction, bronchial hyperresponsiveness, airway obstruction, and asthma symptom. So what I simply say is whether the antigen is presented to the mast cell or is presented to the T cell, end result is the activation of the cytokines which lead to increased release of immunoglobulin E, Th2 responses, activation of eosinophils, leading on to immediate symptoms in terms of bronchial constriction, followed by persistence of inflammation, which could be subacute or chronic depending upon the continuous exposure and the genetic predisposition of an individual. Early phase reactions usually, as I said, occurs within minutes, and this is another cartoon which says and which shows there is a degranulation of mast cells leading on to amniosynthesis, which leads to what we have discussed so now, release of histamine, proteases, and newly generated mediators. And the symptoms will be obviously air obstruction, which is manifested in forms of wheezing, coughing, shortness of breath, tightness of chest, and sometimes pain as well. Therefore, hallmark is airflow obstruction, which we clinically see, but the basis of this airflow inflammation, of this airflow obstruction, primarily is inflammation. Now, this inflammation, as we have talked and discussed now, can lead to acute bronchoconstriction, airway edema, chronic mucus plug formation, and airway remodeling. In simple terms, early component is related to histamine and proteases and leukotriene release, and the later phases, which you called as an airway edema, is a consequence of these substances which have been released, and they are responsible for, including slow reacting substance of anaphylaxis, for late asthmatic responses. This leads to increased edema and exudation of proteins, which leads to formation of plugs, and it may take a longer time to resolve, and that can explain persistence of symptoms. And some patients may also go because of the continuous stimulation by cytokines, as well as there could be other pro-inflammatory factors which can lead to hyperproliferation of bronchial muscles, as well as other cells, to airway remodeling, and it can have a profound effect on the reversibility of airflow obstruction, which otherwise is a classical hallmark of asthma. Now, what it simply means is when there is an airflow obstruction, there is much easier in these circumstances for relatively air to get into it, but difficult for the lungs to expel the air, resulting in hyperinflation, which leads to alteration of pulmonary mechanics and increase in the work of breathing, because of which person complains of breathlessness, tightness in the chest. Now, this is another cartoon which is explaining airflow obstruction. That what we are seeing is that an airflow adhesions are being produced. They are going again acting on a review of what we discussed on macrophages, dendritic cell, mast cell, leading on to marked action on bronchial mucosa as well as bronchial musculature. You have a mucus plugging, you have a nerve activation, epithelial shedding, and there is also subepithelial fibrosis as the result of remodeling and leading on to permanent airway obstruction. And the net result of all this is airway obstruction, inflammation, and persistence of symptoms which are there in cases of asthma. So short and summarize this flow diagram summarizes it completely. You have a triggers which could be infection, allergens, exercise, or irritants that leads to IgE mast cell mediated responses or dendritic cell presentation leading on to that lead to release of cytokines, chemokines, and like interleukins, etc. Now, and acting on the white cells, different ones, eosinophils, neutrophils, mast cells, as well as they act on macrophages and lymphocytes. You have an earlier phase responses where peak will be within half an hour to 1 hour, which leads to bronchial smooth muscle constriction that is predominantly followed by secretion of mucus. There occurs a vascular leakage and mucosal edema. On the other hand, when there is a late phase response, which you see 6 hours to 12 later on, followed by 5 to 6 hours, but they peak in between that time, you have an infiltration at that point of time of the bronchial mucosa takes place with eosinophils and neutrophils, and there occurs a bronchial hyperreactivity with inflammation. Then within 1 to 2 days, you will see it is followed by an infiltration by monocytes and lymphocytes. The net result is a significant disinflammation is obstruction, air trapping, respiratory dysfunction, and feeling of breathlessness and hypoxemia. In acute cases, it worsens, and hence the symptomatology also worsens. Therefore, now let's come down to the natural history of asthma. When you see it, then you have a disease risk which is decided by the genetic predisposition. Then there occurs a clinical evidence of a disease or a disease induction. Then the symptoms of the disease persist. That is what you look at, disease consolidation. And when you see there occurs an airway remodeling or perineal inflammation, along with it, when we see there occurs a recurrence of symptoms or perineal symptoms, we say disease is progression, which is interspersed or punctuated by worsening of symptoms, which we called as exacerbations of asthma. At the same time, as we said, and we talked about it when we are talking in terms of disease consolidation or disease progression, inflammation has been taking is the center stage, is the most important thing which is responsible for it. And you can have two components. One is an acute inflammation, another is a chronic inflammation. When we are talking in terms of acute inflammation, which is as a result of trigger, it leads to release of mediators and symptoms. On the other hand, when you have a chronic inflammation in the background of susceptibility genes, same thing happens also. We should see it in acute inflammation. So susceptibility genetic is important. That is what decides disease risk. What we see is that early environmental, maternal programming, etc. also play an important response, whether it will be Th1 or Th2 responses. When you see that with the genetic predisposition, with the maternal and early life programming, environmental programming, which plays an extremely important role, there is a significant leading on to formation of chronic inflammation, which again tends to get interspersed by acute inflammation, which we clinically see as exacerbations. Now that leads to tissue remodeling with the influence of growth factors and cytokines, which again initially you will see there will be variability of responses. Later on, if there is a significant remodeling, there may have a difficulty in terms of variability of symptom to that extent which one has seen it beginning, and that leads to clinical symptoms. Therefore, you will see the simple thing which you must understand clearly is that it starts from predisposition, then environmental factors, both maternal and postnatal, come into play, which incites acute or chronic inflammation as a consequence of Th2 responses and in responses to allergen, viruses or pollutants or diet. That leads to formation of inflammation, clinical symptomatology, and which under the influence of cytokines and growth factor leads to airway remodeling and variability in inflammation that is finally defines the symptom complex. Hence, now again I am re-emphasizing the point that we must say that asthma is an inflammatory disease, and we must know how this inflammation happens, occurs and follows, because unless and until we are not going to break the cycle of inflammation, we will not be able to treat asthma appropriately. Another interesting thing which has come up and which is defining a certain variability is that identification of Th17 cells. Now this is again a new player which has come up in asthma pathogenesis, and this you see in those cases which are relatively steroid resistant and where we find dominant neutrophilic airway inflammation or airway response. And this is important, and that's what we are seeing in the lower, this from the allergic asthma to steroid resistant asthma, where you see from eosinophil it shifts over, is taking place to neutrophils, and it is Th17 cells which are primarily deciding, and you will see the cytokine profile entirely changes in these cases. And instead of IL-4, which has been predominant, which led to Th2, here what we are seeing is the interleukin 1 beta, interleukin 6, 21 and 23 playing an important role. Therefore, now you will agree with me that it is a complex disease, and as a result of a variability in pathogenesis and predisposition, we are finding disease variants with different underlying pathophysiologies. Endpoint is the same, but the factors which lead to this could be different. Therefore, it is important that limited knowledge of this mechanism is a great obstacle, therefore, in identifying what is the consistent genetic and environmental correlation, so that we can act at that level and prevent the onset of asthma. Another important thing is the understanding the causes of asthma, because what initiates or triggers the symptoms of asthma, that all depends upon understanding what leads these triggers to leading on to stimulation of this type of inflammation. Then you need to identify disease subgroups so that treatment can be individualized to an individual, and obviously if we know all these things, improvement of treatment is going to be there, leading on to better patient satisfaction. Yeah, this leads us to another interesting aspect of asthma, because when we talk in terms of individualization of patients or a group of patients to see the most efficacious treatment, it is extremely important to know their presentation and the genetic predisposition. Do they have a similarities, or they are different to each other? And that is what clinically defines the various phenotypes and endotypes of asthma. Historically, asthma means there is a intermittent symptoms which we have defined earlier as a variability of symptoms. On the other hand, when they realized that later on it was an exposure of an allergen which led to this thing, they started calling it as an extrinsic or atopic asthma. When steroids were discovered and it was given to these patients, it led to an excellent response of the management, and that is what led to a concept that predominantly it is a eosinophilic chronic inflammation. Subsequently, people realized that a fair number of patients failed to respond to corticosteroid, leading on to the concept of corticosteroid resistant asthma. Now we know there are different subclinical groups of asthma, and there are a heterogeneity in terms of symptom triggers. Some get triggered by a cold air, other will come with some drugs, other will by allergens, pollens, etc. And obviously the pattern of airflow obstruction, depending upon them, could be perennially inflamed, chronic inflammation, could be subacute inflammation, or there could simply be an acute inflammation. Now these things associated with different exacerbations and obviously association with different comorbidities in these patients led to a concept of phenotypes. Now that leads to a question, what is a phenotype? Phenotype is nothing else but it is a clinical manifestation which we are saying here as an outward manifestation of an individual's underlying genetics as well as the influence of environmental factor and the interaction between the two. What does it mean? It simply means that a person who has a genetic predisposition interacts with the environment of his or her, and what these combination of these two together lead to end of the day presentation of sign and symptoms. Simple words, how a person presents clinically is a net result of two interactions, genetic predisposition and environmental factors. So that's what defines a particular phenotype. No specific phenotype by and large till date have been broadly agreed, but what we know today is there are clinical, genetical and statistical approaches have been yielded many phenotypes leading on to confusion. Phenotypic subgrouping of bronchial asthma is done keeping various factors in life. First and foremost is what is the age of onset. Then you look at it whether person has an atopy or not. A particular risk factor is identifiable in an individual which predisposes a person to asthma, like an exposure to a particular allergen. How person is responding to the treatment, be it a long-acting beta agonist or primarily to the inhaled corticosteroids. Is there any comorbidity associated, primarily obesity? What is the duration of signs and symptoms and the frequency of exacerbation, and what is the type of inflammation? In fact, bottom line is the type of inflammation, but having said so, with the same sort of inflammation, presentation can be varied and which depends upon number of the factors which I just discussed. Now that is another concept what we called in terms of an endotype. Now they are very helpful in terms of defining potential therapeutic targets, but not all mechanisms which predisposes to the asthma are not identified. What we look at is that initially we will have an asthma endotypes. They are nothing else but they are distinct disease entities which can be present in clusters of phenotypes. That means there could be certain groups which will be presented, but each has a separate different biological mechanism. It means there could be a single phenotypic presentation of a particular endotype, and that means that we are seeing it here, a person, how inflammation has been done as a response to the genetic factors which are there are present in that individual. And now that leads to asthma phenotypic characteristics, and these are the observable characteristics having no direct relationship to the disease process, including physiology, triggers, inflammatory parameters. That's important. And then obviously all these things then lead to asthma syndrome, symptom of asthma variable airflow obstruction. Therefore, it's a three-step process where you have an endotype, you have a phenotype characteristics, and you have an asthma syndrome. And this is how we look into it. Now, if you see, this is a progression of phenotypes to endotypes. Now, phenotypes are nothing else but these are overlapping clinical, physiological and hereditary characteristics which defines a particular subgroup of patients of asthma. The molecular phenotype is when with this clinical phenotype we incorporate pathological processes ideally at a molecular level, like we are looking at a cytokines. Now, when you talk in terms of phenotype, it is confirmation through the molecular targeting, which identified the molecular pathways contributing to the clinical characteristics along with the molecular phenotypes. So what we are trying to do is we look at identify a particular asthma phenotype. Then you try to find out what sort of a molecular phenotype or the cytokine secretion which are there, and from there you go retrogradely and try to find out what is the predominant molecular abnormality or the genotype which is responsible for causing this sort of a release of molecular chemicals which we identify clinically as a phenotype. So it's a three-step process, and we have gone retrogradely from phenotype to molecular phenotype, molecular typing, and then to endotyping. This was a famous article which was published in Blue Journal on the cluster analysis and clinical asthma phenotype, now which has actually created a lot of Let's look at it. What it showed is if you take on x-axis the eosinophilic inflammation and if you see on the y-axis the symptoms. Now they have been putting into three different groups. One is where the asthma symptoms are concordant and both up and down the graph you will see there is a discordance. Now what we are seeing is when you see on the x-axis, on the y-axis there is a discordant symptom, that means symptoms are much more than inflammation, or in the lower quadrant what you are seeing is that there is a discordant inflammation where inflammation is more than the clinical symptomatology, and there is a large chunk in between in the center where the concordant disease is there. And when we talk in terms of concordant disease, it is a symptom based approach to therapy. Titration may be sufficient. That is what we are looking at it. What it means is that you can have a benign asthma where you will have a mixed middle-aged cohort, well-controlled symptoms and inflammation. It's a benign prognosis. It means it's an excellent prognosis. There could be an early onset atopic asthma which can have a concordant symptoms, and along with there is an inflammation and airway significant dysfunction, and this is a large chunk of patients which we do it. The yellow color telling you about a primary care which you see it, and the blue which we say in the secondary care commonly. On the other end, when we are talking of a discordant inflammation, dominantly we pick them up little later in the secondary care, and here what we say is that it is a late onset, greater proportion of males and a few daily symptoms, but there is an active eosinophilic inflammation there which you can see in terms of both in the blood as well as in the sputum eosinophils. And here you need to monitor inflammation, and that tells you because it's an eosinophilic and the steroids are an excellent drugs for it, and at the same time you can titrate the doses of steroids as per the presence and absence of eosinophils. On the other end, when we go to the discordant symptoms, what you will see is early symptom will be predominant. It will have an early onset atopic, normal body mass index could be there, and in these cases high symptom expression is going to be there, and there could be frequent exacerbation. That's very important. And here again you need to monitor inflammation, and probably in these cases where you do not have that much of an inflammation, probably you may have to use other drugs which have a different mechanism of action than corticosteroids. On the other hand, there is another variant of it, is an obese non-eosinophilic, which will be late onset, female preponderance, and there is a high symptom expression with exacerbation and are difficult to treat with steroids. So when we know this basic graph, it becomes much easier for us to manage these cases. Now, what is the importance of the study? As I said earlier, stepwise approach, we have been talking and dealing, whether it's a GINA or any other guidelines, that you increase the dose of ICS or inhaled corticosteroids if inflammation is not responding. But this is relevant only and only in concordant asthma, which is dominantly we are seeing with patients of eosinophilia. But in those who have a discordant, if you find symptoms, as I said earlier, more than inflammation, increasing the dose, I said before, will not lead anything. Therefore, you need to try alternate drugs. On the other end, when inflammation is more than symptoms, you need a higher dose of corticoids, inhaled corticoids, but there may not be requirement as much of a bronchodilation. Therefore, in severe diseases, sometimes you may have to end up actually giving these subgroup of patients either oral anticoagulants or the biosimilars. Now let's look at the first and foremost, we talk about allergic asthma. Allergic asthma, usually you will see it in a childhood or an adolescent, but can also be later. It is the commonest phenotype of asthma which we see. Commonly in males, there will be a history of other atopic disorders like allergic conjunctivitis, eczema, or allergic rhinitis, and family history of allergy is common. Exercise-induced symptoms are frequent and they are severer than the non-allergic. And we define it by the presence of hypersensitivity to airborne allergens, and there are certain things which needs to be there. One is sensitization, and second is a clinical correlation. Sensitization is mandatory and clinical correlation is desirable. And what we see is perennial sensitization, exposure, seasonal symptoms, and we need to look at it whether it happens to the exposure to some allergen like glass or pets. That's important. And dominantly, this is what we describe as a Th2 dominant inflammation. And again, here in both sputum as well as in the blood, you see eosinophilia, and severe asthmas, inhaled corticoids may be less effective, and you may need anti-IgE elements like omalizumab, which is a biosimilar. When we talk in terms of non-allergic asthma, it is seen in patients whom allergic sensitization which we said is required for the confirmation of allergic asthma and is not there. In simple words, here we find that allergic sensitization is not there, and that is we pick up by negative prick test or RAST testing. There is a minimal panel for perennial allergens. There will be another important and interesting aspect will be normal or low immunoglobulin E levels. The clinical characteristics of it is going to be, it will be late onset, it will be seen in adults, this will be a female predominance and usually up to 10 to 33% in various series. And then symptoms will be perennial and severity can be more severe than allergic asthma, and they are going to be less responsive to steroids. That's important to remember. Another interesting aspect which is related to is called an aspirate exacerbated respiratory disease, which is now known as a special phenotype of asthma. In this case, some will react and you take a non-steroidal anti-inflammatory drug or you may take aspirin. You will find that there can be an acute breathlessness, nasal congestion like rhinorrhea or nasal obstruction along with presence of polyposis. What we see in these cases is there is a classical aspirin triad syndrome which we call off chronic rhinosinusitis, which is complicated by polyps and severe bronchial asthma. And in the various series, it is between 5.5 to 7.3 cases, especially, and you will see it that as the asthma patients which have got a combined method who have a severe incidence is much higher, and so usually these patients have associated rhinitis. Usually we see in a young adult, there is no racial predisposition, but we know it is associated with certain HLA serotypes which are there, and the clinical feature is that a major risk factor is outpatient as ASA may induce severe life-threatening asthma. That means if somebody takes any non-steroidal anti-inflammatory drug or aspirin can have a precipitation of acute severe asthma right there immediately after its ingestion of the drug. Rhinorrhea nasal congestions can be the first symptom and asthma could come later, but they are poorly responsive to the treatment. Anosmia is not uncommon, and asthma and aspirin sensitivity becomes apparent more than 1 to 5 years after the initial symptoms of upper respiratory. Refractory period to aspirin and COX-1 inhibitor is 2 to 5 days especially. That means you can desensitize these individuals, but this stays only for a short time. Another quality which you see is a type is an infection-induced asthma. This is an individual which a respiratory tract infection influences asthma, and commonly you tend to see it with viruses. It can be associated with the new onset disease in both children and adult, or it can be the only mechanism of exacerbation, or there could be a number of other factors. Comorbid conditions are not unusual like sinusitis, and it is associated commonly with persistence or severe disease. Agents, as I said, most of the time are the viruses, respiratory syncytial rhinoviruses are the one which are common, but there's a long list which is there. And in this, what you will see, viruses leads to the epithelial and cellular damage, which leads to release of mediators, chemotaxis immune responses, and because of cellular damage, irritant and allergen penetration improves, and that has a significant neural effect causing bronchospasm, airway inflammation, edema, all the features which precipitate asthma and can also cause acute exacerbations. Similarly, this is what you see in person. There is another subgroup which we call as a recurrent exacerbation, and viruses takes an important role, and they will find it out. They lead to significant enhancement of exacerbations and inflammation. Exercise-induced asthma is again another phenotype or a subgroup of a patient, which is better known. We call it as exercise-induced bronchoconstriction. And you see that a person who is in an activity, following an activity, develops a significant bronchoscopy in 5 to 10 minutes. That's how it happens. And the primarily causes evaporative heat and water loss from the airway. Exercise-induced bronchoconstriction, as I said, occurs within 5 to 10 minutes, and the peak will reach in 10 to 15 minutes within half an hour or so. And along with it, you will see a significant reduction in FE1, which is defined by more than 10% fall. Again, once you have done it, it may be followed by a refractory period of 4 hours during which repeated exercise is going to cause less bronchoconstriction, or you can say there is a tolerance to this effect. Once it has occurred, symptoms can be reversed with standard beta-2 agonist, or you can also use other anti-inflammatory like mast cell inhibitors, or you can also use leukotrienes. As I said earlier, that an exacerbation-prone asthma, this is a 10-hour study which was done for the epidemiology and natural history of asthma. What was found out in that study was that severe exacerbation requiring an emergency room visit or hospitalization in the past 3 months in this study significantly increased the risk of having recurrent future exacerbation. That means odds ratio was very high, 6 times more than the control in this particular group. And this is independent of demographic and clinical factor. What it simply says is that there is a small subgroup of asthmatics whose susceptibility to exacerbation is independent of traditional measures of control. That means they have a genetic predisposition or they have an endotype where you will see that more and more exacerbation will occur compared to the other group of people. In a European network study, they wanted to study the mechanisms and they find it out. Subgroup with prior near fatal asthma exacerbation, this is where they would saw it. And what they found out that it was similar to mild to moderate rather than severe asthmatics with regard to clinical and inflammatory part. But what was very important was that it was distinguished by medication non-compliance A, poor asthma control B, and less use of steroids. Therefore, it is important is that the interventions like education, compliance, and use of inhaled corticosteroid or more prescription of ICS to them is going to reduce the incidence of recurrence. This was another study which was there, inflammatory and comorbid features of patients' severe asthma and frequent exacerbation. What the study showed and which was concluded that it may be a distinct susceptibility phenotype with implications for the targeting of exacerbation prevention strategies as we discussed below, and infections, especially viruses, do play a role. So clinical characteristics, they will be cigarette smokers usually. There are going to be psychosocial factors. There could be a medication non-compliance, and there could be significant associated comorbid conditions like rhinosinusitis, obesity, GRD, and non-steroidal intolerance. Intrinsic host factors for asthma in this particular subgroup are being identified, and I said viruses are one of the most important. And the prevention we have already discussed. In these cases, important is the inhaled corticosteroids, LABA, leukotriene. Similarly, in those who are not otherwise responding in eosinophilic inflammation, you can have a use of biosimilars. Now, when we are talking about a persistent airflow obstruction, then in the patients of asthma, they are a separate subgroup, and this is primarily because of airflow remodeling. And risk factor early identification is important to prevent this particular variety of asthma. And most of these patients, you will see they have an early onset of asthma, they have a longer disease duration, they will have a severe asthma and low, which will be significantly, you can see in terms of low FEV1, non-atopic disease, and there will be a significant absence of rhinitis. And similarly, we can see in these patients more inflammatory cells in the sputum and the greater smooth muscle areas on transection. Importance of identification is to not to misdiagnose as a COPD, and along with that is what you called an asthma COPD syndromes. Avoid overtreatment simply based on pulmonary function, and early identification of those risks, intensive follow-up and management. Now, these are the phenotypes ones. You can see it on inflammatory markers. Here you will see it that a significant portion actually is by eosinophilic, followed by a posigranulocytic, and a small component will be neutropenic, will be a 16% so with the neutrophilic. And it is important to identify in terms of response to that treatment. Now, if you see this cartoon, we have 4 components of it in this. On the top, we have eosinophilic. On the bottom, you have a non-eosinophilic. Left, you have a childhood onset. On the right, we have adult onset. So what we have done in this is that there have been 2 components, the age, which is an important one of onset, and second is the eosinophilic or non-eosinophilic components. What you will see is that in the upper half of the square of this semicircle, you will see allergic asthma, which will be there. Another component will be occupational asthma, cough variant asthma, aspirin, exacerbated asthma, and intrinsic asthma. As you go down, it will be infection-related, cigarette smoking, air pollution, or occupational asthma. Similarly, another comorbidity, obesity, also tends to overlap between both these conditions. And commonly in children, what we are seeing is an allergic. It is in the adults, we see a different varieties of asthma like occupational or intrinsic or cough variant or aspirin induced. So if we compare eosinophilic and neutrophilic asthma, you will realize that in eosinophilic asthma it is Th2 response, whereas in a neutrophilic it is Th17. and in addition it will be eosinophilic is going to be an early onset allergic asthma, whereas neutrophilia you will see allergens and other environmental trigger, as I said before, they will with stimulating Th17. Increased bronchodilatory responses, lower lung function, poor control and increased exacerbation is a hallmark of eosinophilic inflammation, whereas a severe asthma phenotype having corticosteroid resistance you will see with the neutrophilic inflammation. Now corticosteroids, they do cause eosinophilic apoptosis, whereas the corticosteroids inhibit neutrophilic apoptosis. Biological, again the pattern there you will use against Ig2 in neutrophils, whereas we will use anti-IL-5 monoclonal antibodies in patients of eosinophilic asthma because that is driving the inflammation. Obese asthma phenotype is another important component, which is early onset allergic asthma. Pathophysiologically is consistent with the early onset allergic asthma and is complicated by the development of obesity. Late onset asthma mechanisms are poorly defined, more common in female. In simple words, early tends to behave or occurs like as is happening in eosinophilic or early onset allergic asthma. Whereas it is the late onset asthma where we have a poorly defined mechanism which is commonly in females, which responds poorly to steroids, is a challenge. And what we see is with an obesity, there is an early closure of airways, and probably obesity itself might be leading on to inflammation, and as a result of the adverse effect of obesity on pulmonary function, that these patients may be having a significant symptoms then could be explained simply by the pulmonary function. This is a cartoon which shows the differences between obesity-related late onset asthma bronchial on the left side and obesity-related early allergic bronchial. And what you will see, another important component is very thickening of the bronchial muscles, which we see patients who are having asthma right from the early days. Therefore, what is important is that we need to differentiate it because severity is much more, if you see, or the airway remodeling is much more in early onset atopic with obesity asthma. But later on, when you are seeing it, there is an increased airway closure, etc., is probably what we now consider today is a consequence of obesity, and there is a significant airway hyperresponsiveness which is there to the environmental insult. Here you are seeing, here is a systematic cytokines which are causing the inflammation and mucus loading as you see in eosinophilic, and you will see a significant difference in terms of appearance of bronchioles in both these conditions. That means inflammatory microenvironment is important, and that's what I said before, that probably today we know that the adipose tissue is a site of inflammation in obesity, and that may be contributing, and hence the cytokine profile could be different or adipokine profiles can be different. If you see it in the two variations, early onset and late onset with obesity, what you see in early onset, to summarize, it will be increased atopy and allergen in this younger age of onset, and cytokines are as of Th2. On the other hand, when you see it in the late onset, what we find out that it is tidal volume mechanically restricted, exacerbations tends to be reduced with corticosteroids, metabolic inflammatory markers are increased, airway closure is improved if you by the weight loss, and weight gain increases severity of asthma, and again they are reduced by the weight loss or if you keep the weight stable, and there is a lower markers of eosinophilia. In other words, in early onset you will see all the signs and symptoms of early onset asthma, that is allergic eosinophilic asthma. In the late onset you will see that the cytokine profile is that of the obesity as well as a consequence of mechanical properties of obesity, and when you lose the weight you tend to improve in the symptoms. Work-related asthma is another group of asthma which is an important occupational hazard. Occupational asthma could be allergic or irritant induced. Allergic asthmas usually are a result of high molecular weights which are there, whereas in irritant-induced asthma, we also call it the reactive airway dysfunction syndrome. Work-exacerbated asthma is triggered by various work-related factors such as irritants of exercise in workers who are known to have concurrent or pre-existing asthma. What is important to realize is pattern of inflammatory responses are different to high molecular and low molecular weights. High molecular weight agents usually are Ig mediated, whereas the low molecular weight act as haptens, and they require conjugation of a host protein for their manifestation. IgE independent of occupational asthma is caused by low molecular weight asthma, and this is also called as immunological occupational asthma. There are other mechanisms which have been proposed which could lead, obviously once inflammation is there, microvascular leakage, direct pharmacological effects and neurogenic inflammation. Histopathological features of reactive airway dysfunction are poorly characterized. What we know is that there occurs in epithelial desquamation, bronchial wall inflammation including infiltration by lymphocytes, plasma cells, but not eosinophils. That's important. And absence of mucoscleral hyperplasia, which is commonly seen in patients with bronchial asthma, basement membrane thickening and smooth muscle hypertrophy, which is a part and parcel of airway remodeling, are not seen. Symptom-based phenotype, you can divide it into a shortness of breath phenotype, cough phenotype, or a wheezy phenotype. What is important is that it is a shortness of breath phenotype, which is commonly associated with high elevated total serum IgE, and whereas in a cough phenotype, we find increase in both serum as well as sputum eosinophils. And in a wheezy type, there is also an increase in peripheral eosinophils and sputum eosinophils. So in other words, when you are looking at shortness of breath, cough, wheezy, a fair number of these patients you will see eosinophilia, especially where you are having an eosinophilic inflammation. And majority of them you will see when it's a shortness of breath, it will respond to inhaled corticoids. If it is a cough phenotype, which you commonly tend to see in a female predominance with a shorter disease duration, in these cases with a positive family history, predominantly their response is to Montelukast. On the other hand, when we are talking to the wheezy phenotype, then it will respond to both inhaled corticoids as well as to Montelukast. Therefore, my dear friends, to conclude, considerable progress though has been made in the past few years to define and understand the pathophysiology of asthma, but still challenges remain and we need to further refine and define if each and every subtype or a patient of asthma. As new therapies for asthma becomes available, substantial effort is needed and required to define and understand who is going to respond to these therapies so that right therapy can be given to the right patient. In turn, these targeted approaches will aid in the identification of better biomarkers for certain phenotypes. Simple to say that identifying the phenotype should ideally tell us the type of endotypes or cytokine or molecular profile so that the treatment can be adjusted according or can be streamlined or can be tailored to the need of the patient. And finally, by identifying asthma phenotypes, as I said before, more appropriate, effective and safer therapies for treatment of each phenotype can be done or will be possible. Thank you very much.